Excellent. All right. Welcome, everyone, to today's presentation. Yes, it's still here, and so is the flu, an update on COVID-19 and the seasonal flu. My name is Marta Alvarado. I'm the manager of online education for Migrant Clinicians Network and moderator of this session. Next slide, please. Let me go back to that first slide. Let's go back. Sorry. I just wanted to mention one thing before we get started. I want to tell everyone that I will be sending a follow-up email later this afternoon that will include the links to download the PDF versions of the slides, to access the evaluations, the recordings, and resources related to this presentation. Now we can go to the next slide, Oksana. Thank you. This presentation is being simultaneously interpreted into Spanish. To listen to this presentation in Spanish, locate the globe-shaped icon on the Zoom toolbar, click it, and select Spanish. Next slide. To view the Spanish language slide deck, at the top of the screen, there is a View Options tab. Click on that tab. A drop-down menu will appear. Select Español. Next slide. A reminder that this session has been approved for continuing nursing and medical education. In order to receive 1 hour of continuing education credit, participants must attend at least 80% of the session and submit the post-session evaluation. Next slide. To comply with the accrediting agency's requirements, I'm just going to go ahead and read the disclosure. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. This presentation is supported by a grant for the National Center for Farm Worker Health. No one with the ability to control content was found to have a relevant financial relationship. Next slide. Our presenters today are Dr. Laszlo Medeiros and Amy Liebman. I'm just going to introduce them really quickly. Dr. Medeiros is the Chief Medical Officer for Migrant Clinicians Network. As such, Dr. Medeiros is responsible for the oversight of MCN clinical activities. He also serves as a subject matter expert for various topics in migrant and immigrant health, including COVID-19. Since 1996, Dr. Medeiros has been a board-certified family physician in both inpatient and outpatient medicine in pediatrics, adult medicine, and obstetrics. Dr. Medeiros also teaches hospital medicine to Penn State nurse practitioner and physician assistant students and medical residents at Summit Health. Our second presenter, Amy Liebman, has devoted her career to improving the safety and health of disenfranchised populations. Since she joined Migrant Clinicians Network in 1999, she joined Migrant Clinicians Network in 1999 and currently serves as the Chief Program Officer, Workers, Environment, and Climate. With MCN, she has established nationally recognized initiatives to improve the health and safety of immigrant workers and their families. She oversees programs ranging from integrating occupational and environmental medicine into primary care to designing worker safety interventions. Amy has been a strong advocate for worker health and safety during the COVID-19 pandemic, leading programs to improve access to care and culturally contextual education for migrants and immigrants. It's so good to have you both with us. And with that, I'm just going to ask Dr. Laszlo Medeiros to take it over. Take it away, Laz.
Okay, thank you, Martha. And welcome, everybody. Good morning on the West Coast and good afternoon on the East Coast. Amy and I usually start out this talk on COVID over the many years that we've been doing this to say that today is October 10th, 2024, and we bring you the most up-to-date information that we have as of this time. If you're listening to this some other later date, some of the things we tell you may have already changed, and we will definitely try to update you as we know more. But we're going to try to give you the current information as of October 10th of this year. So welcome, everybody. So we're going to go over some objectives here. Next slide, please. So our objectives for this talk. One, we want to discuss the current state of emerging and re-emerging viruses, including COVID-19 and influenza. Seasonal influenza is what we're talking about mostly. And I'm going to touch just briefly on RSV, respiratory syncytial virus also. Review strategies for prevention and treatment of COVID-19 and influenza. and also to identify culturally contextual resources that can be used to address COVID-19, influenza, and other respiratory health in farm worker patients. Next slide, please. So we can see COVID overview since the early years. Now we've been in year 4, and the death toll keeps rising. But as you notice there on the orange graph on the right side, that it's plateauing, which is very good. The death rate has been reducing over time, but still very powerful. COVID-19 still presents much, while there's much reduction in mortality and acute morbidity, it still presents as a problem. One of the things I do in South Central Pennsylvania, where I work as a family physician and a hospitalist physician, is that I see the hospitalized patients who are sick enough with COVID or influenza to be hospitalized. I see them in the intensive care unit, on the medical floor, and then I often send them back to their primary care physicians after they get better. So I've been seeing the steady march of COVID over the months. But fortunately, now we have fewer emergency department visits and intensive care unit admissions as of this month. I see that in my hospital. I've talked to many colleagues across the country who are seeing the same thing. In the last week of September, there have been less than 500 deaths, so 447 deaths per week. It has been the first week, this part of September has been the first week that we've had significantly fewer deaths than over much of the summer, which has still been quite high. Not high as the first years of COVID, but still significantly higher death rate than from almost any other illness. So September, we still are seeing a high death rate, but decreasing over the last couple of weeks. Next slide, please. So who's most vulnerable? Well, many people are vulnerable to get viral infections, including COVID-19. We see that in the elderly, and much of what we see now is that 65 and older get hospitalized more than the younger patients. The comorbidities kind of mount up as you get older also. So COPD, different kinds of lung disease, being immunocompromised, and also being in conditions where you don't have control over your environment, such as our farm workers who often work together on either a type of assembly line or travel together in vans or live together in communal housing. So these are the people who are vulnerable to getting viral infections, including COVID-19. And that really hasn't changed over much of the past year. Next slide. So you can see from this graph that the age group that is still mostly affected are the older patients. So the top line there in that purple color is 75 and older. Just under there is the 65 to 74. So we can say 65 and older. Now, I did mention that it's mostly older people who are more vulnerable. However, over the summer, late August into early September, saw more children 0 to 11 age come to the emergency room with COVID. We think this may be having to do with the start of the school year and people getting together after they haven't been together for a while. Luckily, it's starting to decline. But the bottom line is here, I still would like to see the younger patients also being vaccinated against COVID-19, as well as our older patients and our migrant farm workers. So again, we saw an unusual spike for ages 12 to 15, age 16 to 17, and in 0 to 11 as well. So most of the pediatric population saw an unusually high rise during this time, but thankfully it is decreasing. Next slide. So what are we seeing right now in terms of COVID-19? Well, the variant called KP3 1.1 is an offshoot Omicron variant, and it has been the dominant variant. In fact, about 58.7% of COVID cases during this summer have been the KP3 1.1. A new emerging variant has been noted. It started in Germany, and it's over Western Europe, going to Eastern Europe, and it's coming to the United States as well. This variant is the XEC variant. It's only about 6% currently, as I speak now, in the United States, but it seems to be on the rise. And so this is the next variant that we'll be talking about over the next coming months as we get fall into winter. Now, new variants tend to prelude increases in cases and have a higher chance of being immune evasive. So there is this chance as we get newer vaccines that we keep updating the vaccines as we get new variants. And it's still very important to get those vaccinations updated as they come out, because they do prevent hospitalization and death for the large part. And I speak from direct experience as a hospital doctor. Next slide. So the fall COVID 2024 vaccine is available now. The old vaccine should be off the market all through the United States and hopefully through most of the rest of the world at this time, as we have the new COVID vaccine for 2024. It's one dose, and you can use any of the COVID vaccines available. Those are Moderna for age 6 months and older, Pfizer 6 months and over, and Novavax 12 years and older. So this is something that we've had experience with all these vaccines in the past, but these are all the updated versions of those vaccines. And the Moderna and the Pfizer are still mRNA, and the Novavax is the non-mRNA variant. Some people prefer that, but it can be only given 12 years and above. So these are our choices for fall of 2024. And I strongly recommend that you take these vaccines as they become available in your community. They are now available in South Central Pennsylvania, where I work. Next slide. So when to get vaccinated? So anytime 2 months or greater after the previous dose of an updated COVID vaccine, you can get the new vaccine. If you've recently had COVID infection, you can delay getting a vaccine until about 3 months after your infection resolves, depending on your level of risk. Again, if you're immunocompromised, it means your immune system is not working as well. And so you really should get the vaccine sooner than later. If you're elderly, again, it's probably better to get it sooner than later. But if you've had COVID vaccine, you can wait up to 3 months after your infection to get vaccinated. Next slide. So vaccines, are they available for everybody? Well, for the uninsured now, the free government COVID vaccines ended in September 2024, unfortunately. There may be local immunization programs that provide low or no cost vaccines through your health department or local health center. So in your state, it's important to find your state or local health department and ask if they have the vaccines available. Your local pharmacies should have them as well, and your community health centers may often have them if you have a federally qualified health center in your proximity. So these are important to get to know and see when those vaccines become available. Next slide. So the COVID vaccine snapshot. Now, unfortunately, speaking from last year, the 2023 COVID vaccination, only 23% of eligible adults received the updated vaccine in 2023. And we anticipate for this vaccination season, the 2024 COVID vaccine will be even at a lower uptake. Why is this? Well, I think people just feel like, well, COVID is over. The pandemic is over. We're not really worried about it too much. And so we're just going to just skip this series of vaccinations. And we believe at MCN that that would be a mistake, because, again, the people who don't get vaccinated are the ones ending up usually in the hospital, often delaying ability to recover. And then there's the issue of long COVID, which we'll address here in just a minute. But it's definitely worth it to get vaccinated. And that way I won't see you in the hospital. I won't have to intubate you and put you in the intensive care unit. The vaccines are not the perfect vaccine, but they're better than not having vaccinations. And I really strongly feel this is something we have to do to stay healthy and safe. Even if we get a minor illness after having had the COVID vaccine. It's still better than being so sick that you're hospitalized, intubated, and possibly dying from COVID. It still happens, even though it's not as bad as it had been in years past. Next slide. So going back to prevention, what can we do? What are the best practices for prevention of COVID? It's still the same as it was in 2021, 2022, 2023. Keep your vaccinations updated. Put on masks if you feel like you're in a vulnerable situation or if you feel like you're getting sick. Wash hands often. Keep social distance as much as possible and ventilate indoor air. Your risk goes up if you are in an unventilated, closed environment, if there's many more people together in one space, and if somebody is coughing and may have an infection, COVID, influenza, or any of the other viruses that tend to get worse in winter. Next slide. So masking, masks decrease viral spread. Now, as of now, I put on a mask again whenever I see anybody in the emergency room because I don't know if they have a virus. And before I know what is their illness, I want to make sure that I don't get it and I don't spread it to other patients who are in the hospital because they are sick, they may be old, they may be immunocompromised. The N95 respirators are still your best protection. Consider your risk and risk to others who are vulnerable. So if you're going to do family visits, family picnics, as we get into the holiday season of Thanksgiving and the other holidays coming up, be sure to know who in your family and family circle and friend circle are vulnerable. And then avoid indoor crowded spaces as much as possible. Try to get ventilation as much as possible. These still work. And this works not only for COVID-19, but for influenza, RSV, and other viruses, as we have shown in years past when we wore masks to protect ourselves from COVID-19, and we got the benefit of having lower influenza rates, lower RSV rates, those years that we had those strict guidelines of masking and social distancing. It does work. Next slide. So ventilation, again, ventilation does make a difference. We know that from many studies now. We were one of the first to realize that COVID-19 was airborne and it stays in the air for long periods of time and you can breathe it in. And in closed environments, it's much more likely that you breathe it in than in ventilated environments. The CDC recognizes that now too and says, airborne is one of the ways that COVID spreads. So ventilation, open spaces, it's very important. Avoid crowded indoor settings because they increase the risk. So indoor versus outdoor seating, time spent at the location. These considerations kind of help you estimate your risk, and you want to try to reduce your risk as much as possible. Next slide, please. So then we get into testing. So testing is still important. This is just going to be, you feel like you have the cold, you have something going on that you have a viral illness, please test. Even if you think that you just have a kind of cold, which could still be COVID or one of the other many viruses. What should I do if I feel sick but test negative for COVID? We'll get into that in another 2 slides here. But it is important to test. And you can see there, the C in that little testing area is the control, and the T is the test. So you put it into the sample, which is the S there, and it goes through the test. If the test turns positive and the control turns positive, you know that you're positive. So that is our guideline there of how to test. If the little T starts to turn the same color as the C, that means your control and your test are both positive, and the control just tells us that your reagent that you work with is working. Next slide. So free COVID testing. There are free COVID tests still available. Visit covidtest.gov to get your free COVID tests. I believe there's 4 coming at this point. I have to look into that for sure, but I believe it's still 4 free tests that come to you per request. And for assistance in more than 150 languages, call the number that you see on the slide there. So this is what the testing looks like. Again, the S is the sample site where you put the drops, and the testing and the control are above. Next slide. So again, the question on the last slide before says, what should I do if I'm sick? Is staying home still recommended? So the basic message we want to give is that it's important to stay away from the most vulnerable people. So the timeline for vaccinated, unvaccinated people. If you are exposed, testing and masking is best, but not absolutely required by the CDC. If you test positive and you think you have COVID, stay home and away from others until 24 hours after a fever has ended and overall symptoms are improving. During this period of 5 days after you have been fever-free for 24 hours and symptoms are improving, then it is recommended to test again, wear a respirator like an N95, distance yourself, and improve air quality and hygiene, especially around those who are the most vulnerable. For testing and isolation information and other information for special populations and environments, please check the CDC. They update their recommendations and guidance every couple of weeks. Next slide. So again, we do have antiviral treatments, and I use many of these in patients who are about to be hospitalized or are already hospitalized. Again, who are those at risk? I'm going to go over that one more time. The older population, age 50 and over, which is me now. Cancer or chronic kidney disease, liver disease, or lung disease, such as asthma or COPD, which is emphysema. If you have these and you're dependent on oxygen, for example, your lungs have less resistance and more likely that if you get a case of COVID or influenza or any of these viral illnesses, that you have less reserve to fight back. So this is really important then to get the antiviral treatments. If the previous vaccinations didn't protect you enough, we will have other antiviral treatments available. If you have diabetes, we realize that diabetes also is a type of minor immunocompromised condition. Obesity with a body mass index that is greater than 35, for example, makes you at greater risk. If you have certain heart conditions, and again, if you are immunocompromised, let's say you have received a kidney transplant or you have an autoimmune disorder and your rheumatologist puts you on immunosuppressing medications, then by nature of those medications, you can be immunocompromised. So please talk to your physician or healthcare provider if you think that you may be in any one of these conditions that may have not been diagnosed. But part of my job as the doctor in the hospital is to provide some of these antiviral treatments for you, and so can your primary care provider outside the hospital if they know you well and know your conditions. Next slide. So Paxlovid is a combination of nirmatrelvir and ritonavir. This medication has been out now for a number of years, and it's still good. It's still used for all the different variants that we've had encountered over the years. All the variants of COVID seem to respond to this Paxlovid medication. There is some guidelines to make sure that other medicines that you're on don't interfere with the Paxlovid, and I'll show you where to look for that information. But your primary care provider should be able to tell you if you are safe to take Paxlovid. I often give this as patients are about to be hospitalized, but before they actually are very sick with COVID, with requiring oxygen or other medications. So Paxlovid is very useful. It's given for 5 days, and it should be given within 5 days of you succumbing to COVID. Another medication I'm going to talk about just briefly here, this is very interesting, metformin, which is a diabetic medication. It's a biguanide medicine that has been out since I've been in residency, so about mid-1990s. And it's been very well tested and given to diabetics who don't necessarily need insulin or as an adjunct to insulin. But a test is ongoing right now in the NIH with metformin being tested with other patients who are diabetic and not on metformin. And as we move forward in time, we're seeing that those people who take metformin for diabetes versus those who do not take metformin and take other medications for diabetes, the ones who take metformin seem to have less of a problem with future COVID and with long COVID. Specifically, long COVID has been shown to be significantly less in those diabetics who are on metformin. And so this ongoing study right now is asking a question: can we give metformin to people who are not diabetic but have COVID and are at risk for having long COVID? I have not had much experience with using this personally in our COVID patients, but I have had a lot of experience using it in diabetic patients over the last nearly 30 years. So it is a safe medication. It doesn't seem like there's many downsides to doing this, but it hasn't really been popularized yet. But I think it's going to be an important, and I'd love to come back in a year and tell you more about it as this NIH study moves forward. But this is one of the exciting possibilities to help us prevent COVID reinfection and long COVID especially. Next slide. Okay, so clinical considerations for antiviral treatments. So there are interactions with other medications, and this is something that we can look up at a site that I can show you a little bit later. But they do have, Paxlovid does have some interactions with other medications, some other psychiatric medications, some medications which prevent blood clots, which are the antithrombotic types of medications, and others. So your primary care clinician should be familiar with this and make sure that either you're off those medications temporarily while you're on the 5 days of Paxlovid, or some other combination of medications could be given in that time. Paxlovid does have a bitter or metallic taste, and that's the most common side effect of Paxlovid. There are some GI symptoms, and there's a concern for COVID rebound. So once you stop taking medications, sometimes 2 to 8 days after the initial recovery with COVID, there are recurrences of symptoms or a new positive test after testing negative. Nevertheless, it's much better to take Paxlovid than to just risk going through COVID in the full infection. This also helps prevent long COVID in the future. So there's 20% rebound using Paxlovid. So 80% do not have rebound and feel much better right away. Usually mild. These symptoms are usually mild, but patients can be infectious during that time. Next slide. Okay, there are additional considerations. Paxlovid broken down kidneys, and you can renally dose the Paxlovid to be less if your GFR, your glomerular filtration rate, is greater than 30 mLs per minute to less than 60 mLs per minute. So those are moderate renal impairments. You can still use the Paxlovid, but just dose it renally, which means dose a lesser milligram dose. Paxlovid is not recommended for people with severe kidney disease and hepatic or liver impairment. So if you're greater, if your GFR is less than 30, that signifies severe kidney disease. So depending on how your doctor can look at your kidneys, filtrating will determine whether you have mild, moderate, or severe kidney impairment. And for severe, don't use Paxlovid. Paxlovid reactions to medications for depression and mood disorder, like I said, these can be severe as well in some, but not all behavioral mood medications. So this is, again, something to consider. Next slide. So again, the tools for drug interaction, there's a lot of different things to look up, and sometimes it's hard for your primary care provider to know them all. But this site will give you the guidelines to the reactions Paxlovid may have with other medications. So we'll leave that for you on this slide, and I will move on here. So next slide, please. So the The treatment of Paxlovid is that first category, which we just talked about. It's for adults and for children aged 12 years and older. And when to start this? As soon as possible, but must begin within 5 days of when symptoms start. And it's taken by mouth. It can be taken at home. I have sometimes given it in the hospital and discharged the patients to continue it at home if they are safe enough to go home. An alternative is the molnupiravir. This is an antiviral that's given. That's the third one down. This is given for adults. Start also as soon as possible. Must begin within 5 days when symptoms start. Taken at home by mouth. So this I use for patients, again, who have some reaction to medications they're on, which makes Paxlovid much more challenging or absolutely contraindicated. So the molnupiravir is a kind of plan B for those who cannot tolerate Paxlovid. Another one is the middle choice there, remdesivir. I use that quite a lot. Now, this is an intravenous infusion, and it makes sense that we give this in the hospital. I've used this many, many times over the last 4 years. You also start as soon as possible, but must begin within 7 days when symptoms start. It's an intravenous infusion at a healthcare facility for 3 consecutive days. If you're hospitalized, I often do 5 days. If you're intensive care unit, I do it maybe 7 days. But it's an IV medicine that you have to give 3 days at least. It can be given as in an infusion at an outpatient infusion center, but a lot of times it's given in the hospital. And I do this for people I noticed becoming hypoxic, and their inflammatory blood markers, their indices, are telling me that they're about to have this inflammatory response and possible hypoxia, that is low oxygen, coming up. And so remdesivir kind of helps that along very nicely and leads to a quicker recovery. Next slide. Okay, for helping uninsured farm workers get treatment, Paxlovid offers this PaxS patient support program, and that's the information there to get that. So this is prescribed Paxlovid for the uninsured farm workers that we have as our clients often. Next slide. So long COVID or post-COVID. So many times after you've suffered with COVID, you have a post-acute sequelae of COVID, PASC, or long COVID. There's a wide range of new or returning or ongoing health problems that people experience after being infected with the virus that causes COVID-19. And this often develops 3 months after the initial infection. That's kind of the definition of the long COVID. And it can last for at least 2 months with no other explanation. So your doctor tries to rule out other types of causes first. So this is long COVID. And again, I mentioned metformin earlier. Those diabetics who take metformin seem to have less of a long COVID or post-COVID experience than those diabetics who do not. So this may be some kind of a treatment that we have. Next slide. So real quick, there are no biomarkers specific for long COVID. Many long COVID symptoms are commonly seen even outside of COVID. Other inflammatory processes can mark this as well. Brain fog, joint aches, etc. These are some of the things that can be in long COVID and other situations as well. 1 in 4 patients with long COVID has significant activity limitations. This is very relevant to our farm worker population because they have to have a very active physical life, and they cannot take a rest most of the time from their activities. So this is a very relevant condition for those who need to be physical, such as farm workers, the other migrant and immigrant workers, assembly lines, poultry, meat industries, dairy industries, where you have to be physically very active. And if you have brain fog or joint aches, muscle aches, general weakness and confusion, it's very hard to work at those jobs. Next slide. So I'm going to talk about seasonal influenza briefly here. So influenza A saw a pickup during the late summer of 2024. The vaccinations are out. The vaccine, Fluvax, is available. It's for influenza A and B as well. Influenza B also arrived earlier in the flu season than usual, although we haven't seen it in many hospitalizations yet, fortunately, but it has been noted in the outpatient setting in South Central Pennsylvania, as I talked to a lot of my colleagues. So the influenza vaccine for the seasonal influenza Fluvax is usually available by September in the Northern Hemisphere. It is now available. Seasonal influenza vaccines can be given with other vaccines such as RSV vaccines and COVID vaccines. So you can get them all together if you wanted to do one trip to your local health facility. It is critical to be vaccinated before your regional flu season begins. If you get the flu, at the same time you get the flu shot, it really won't help. And it will need, 10 to 14 days to really kick in well. So most people would recommend that you try to get it as early as possible. And this being the middle of October now, I think it's a good time to get vaccinated. So if you have it available, please get the influenza vaccine now. Next slide. I'm going to briefly touch on the avian flu, which is not the seasonal flu. This is H5N1, because we've seen that in our farm worker population. It's farm workers that get the avian flu. It's moved from poultry into cows. And so farm workers working in dairy and poultry are the highest risk for avian flu. The general public is not at risk at this time. Again, we're talking mid-October now. We don't see this in the general public. We are not giving a vaccination for H5N1. So the seasonal flu vaccine does not protect absolutely for H5N1, but we want people to get vaccinated for the seasonal flu so there's no opportunity for a farm worker, for example, to get H1N1 seasonal flu and H5N1 at the same time. So the virus has a chance to reassemble and reassimilate and change its genetic material to cause a greater problem for epidemiology and the general health of our farm worker and our general population. So we do recommend getting the seasonal flu, but it does not protect absolutely against H5N1. We are going to have a talk later in October talking about H5N1 specifically, so I won't labor this point at this time. But we're watching it closely because farm workers are getting it from our dairy cows. Next slide. I'm going to briefly mention respiratory syncytial virus. This is called RSV. Its season is November to April. It's coming on. And there's a concern that the RSV is going to come with the influenza this year, as well as COVID. There are new RSV injections for adults and also available for pregnant moms. It's available for age 60 and over and for pregnant moms. The vaccination offers promising results, substantially reducing hospitalizations, also for infants. We had the infant vaccine first, but now we also have the new RSV injections for 60 and over and pregnant moms. And we'll go on to the next slide then. Okay, so consideration for our farm worker populations. Again, patient occupational history. When you see a farm worker, ask where they're working, whether they're working with dairy, whether they're working outside. It's important to get an occupational history, so to know where they're being employed and what kind of work conditions they have. Housing, are they all together in one location? If you're telling somebody to isolate, can they actually do that based on their occupation and their housing? The comorbidities that they have, because farm workers also may have diabetes, they may have other lung disorders. If you're high risk for H5N1, you can know this by people who are working with dairy cattle and warn them of the risk of H5N1. Again, we're going to talk about this in a later October webinar. So it does make being vaccinated against COVID and seasonal flu very important because you're protecting them as much as possible. And if they can only take off work, for one day to get the vaccinations, please try to get the COVID vaccine and the seasonal flu at the same time. And if they're 60 and over, add in the RSV vaccine as well. I think that's the best way to protect our farm worker populations. Also, be sure to use culturally contextual outreach. So making sure that people know why they're getting vaccinated and that this will help them with not getting sick. I know many of our farm workers don't get paid if they get sick. They often don't have any sort of FMLA, Family Medical Leave Act, et cetera. So it's really important, and also to use our trusted community leaders and our outreach workers, our community health workers. And so those are the people that are very important to us to go out and tell what you just learned at this webinar to our farm worker populations. And I really appreciate the work that you guys all do for that. All right, next slide. So what we're going to do is just go over some screening questions for the primary care setting. For those of you who are primary care clinicians, describe, occupation. It's really important. I tell this to my medical students and my residents as well. Whatever you do when you're introducing yourself to a patient, get to know them. What is the type of work that you do? This will help determine the differential of many different kinds of occupational health hazards. Activities and causes. Are there any physical activities that you do at work or away from work that you feel are harmful to you? Another question is, are you exposed to chemicals, fumes, dust, noise, and or high heat at your work or away from work? Do you think that these are harming you? My colleague Amy Liebman does an excellent job in covering these in other webinars as well. So we have much more detailed information on all of this, but please ask these three questions at least as you try to get to know your patients, and therefore can help estimate what are their risks for exposure to viruses and other environmental health hazards. Next slide. Okay, prevention. Again, we talked about vaccines. That's a mainstay. Hand hygiene, personal protective equipment, ventilation. So I'm just recounting all the different possibilities here. How to do prevention before you get sick. Next slide. So in summary, we are going to have emerging and re-emerging viruses. There are going to be seasonal viruses like influenza, and there are going to be other viruses like COVID who may not have a season. We've seen different spikes throughout the different seasons, spring, summer, fall. COVID viruses and their variants seem to emerge at different times, and they're not particularly seasonal. Know who is at most at risk: elderly, children, workers who have difficult settings where they cannot isolate, immunocompromised patients. And again, ask your patients what they do for work. This will help put the risk stratification together. And then prevention is still most important. And make sure patients have the most up-to-date vaccines. That's the whole purpose of this talk today. And next slide. I think with this, I'm going to hand it over to my colleague, Amy.
Thank you so much. Before I get started in talking about some of the culturally contextual materials, I just wanted to alert you to one question that I thought you could answer. That one of our participants asked us, if you're testing negative at home on your home COVID test, but you still feel lousy, should you go to get tested at a doctor's office or a pharmacy?
Okay, so that's a good question. Now, there are some different testing types of testing. Most of the time, your doctor's office and the free home testing that gets sent is pretty much the same. I've seen 2 or 3 different testings. I had some tests at the State Health Department in Pennsylvania, and that's the same one that I got sent from the government as well. So it may be good to test a second time. But most of the time, it's very similar. So unless you have any concerns about your own technique of testing, like you weren't brave enough to really go up that nostril that far, I would say that you probably have the same test, but maybe somebody who does that, professionally can get a better sampling. So it doesn't hurt to do that. Also, if you wait another day or two as you get that appointment, you may test positive at that time, not because your technique was poor, but because you had another 24 to 48 hours and the virus did manifest itself at that time. Okay.
Great. Thank you so much. If you have questions, please go ahead put them in the chat. And I did want to, I know we talked a little bit about H5N1, but please know that webinar will be November 12th, and a registration should be coming to you soon. All right, so we talked a lot about COVID-19 and a few different other respiratory illnesses, and we wanted to just make sure that everyone's aware of some of the resources that you can use to help educate your farm worker patients with. We've developed a number of materials. I'm sure many of you are familiar with them, but we really like to make our educational materials in such a way that we're thinking about what is the reality of the farm worker and their families. How do we connect with them to help them with the messaging that we're doing? And we're always thinking about offering practical solutions, recognizing some of the challenges that may be involved in terms of some of the recommendations that are being made. Next slide, please. So I invite you to all visit MCN's resource hub, and there we have so many editable templates, campaigns, and the templates are really cool because you can take resources and you can put your own logo in them. You can put your local health department phone number in there, your organization's phone number and logo, and really make them so that they're able to be used at the hyper local level. Somebody asked about getting printed materials, but what we recommend is that you visit our hub, download whatever materials you'd like, and print them at your leisure, and you're able to adapt them accordingly. But we have over 300 resources in multiple language, in English, in Spanish, and Haitian Creole. Next slide, please. And this is just an example of our Vaccination is Communication campaign. It really revolved around COVID, but there's a number of images and types of templates that you could use to promote other types of vaccinations with ease. Next slide, please. And here are some printable posters, printable posters. And again, you can also put different images in, images of farm workers that you work with, or if you feel like it would be better off to have a community leader in there, or a promotor de salud, you can do that. And you'll see that there's places where you could put a web link and your phone number in there. And there's all really easy to use instructions on how to do that. Next slide, please. We also are continuing to update our award-winning FAQ on COVID-19, and we're probably due for another update. And I just want to make sure that you're aware that we put out a bilingual resource really with the latest and greatest information around COVID, so that you can be sure that you're getting up-to-date information and recommendations. Next slide. Here's an example of other resources that we have. We talked a lot about ways to protect ourselves from COVID. And here's a really helpful resource regarding the use of N95 respirators and masks, so that you can protect yourself from COVID and other types of exposures. Next, please. We also have a really great flip chart that you can use as a community health worker if you want to educate folks about COVID and why it's still important to get vaccinated. We have resources around ventilation. And again, a resource around ventilation is particularly important for COVID, but for other respiratory and infectious diseases, thinking about ventilation, thinking about facial protection, all of those can be adapted accordingly. Next slide. I just wanted to let you know that I'm hoping you're enjoying this webinar, but we would love for you to help us on Great Nonprofits and go to the site and leave a message about MCN, how we've helped you in your work, or what has been most useful. Next slide, please. Also, feel free to connect with us at migrantclinician.org and on social media. We also have a podcast that we encourage you to check out. But please remember that MCN is your home away from home, and we really have a lot of resources and information that we want to make accessible to you. Next slide, please. And then we also want you to take a moment. We have this awesome award. We give there's a $1,000 associated with it, but we are looking to honor some of our founders in our organization, Candace Kugel and Edzer Weste. Many of you have been on webinars with both of them at some point, but Edzer Weste was our founding medical director. Candace Kugel was our clinical specialist and did a lot on women and reproductive health. And we have an award in their honor, and we would love for you to nominate someone so that we can honor them and really encourage those who are new in the field to keep at it and help us fight the good fight in migrant health. Next slide. So we have lots of upcoming webinars. I already mentioned our H5N1 on November 12th. But we are really looking at a number of different issues. It's a tough time right now in terms of our climate. On Thursday, October 17th, we'll be talking to community health workers about climate resiliency. We also have a 3-part webinar series that's looking at words matter, and we're seeing a lot of really harsh words and rhetoric, particularly rhetoric around immigration. And there's a really great series that we're putting on, and we hope that you enjoy taking part in that webinar. Also, an update on our health network program that focuses on continuity of care and care coordination for migrant patients. Next slide. And then we are also looking at some more pesticides. We had a great first part of our series in I think last week. And then on Thursday, November 7th, we're going to continue with part 2 of that pesticide webinar. And then we also have more on post-hurricane recovery. We're hoping that these topics are relevant. You put this information in your evaluations. We try to be responsive to the topics. And I know it's a lot, but we're hoping that you will help us out and participate in those webinars. Next slide, please. All right. We're going to put the evaluation link in English and Spanish in the chat. But if you have any questions for me or Dr. Laz, please go ahead and put them in the chat or the Q&A, whatever you are most comfortable with.
So as we get to questions, Amy, I also want to add that I want to thank our partners, the National Center for Farm Worker Health, because we partner with them on many different webinars here. And so they're partnering with us on this. So we just want to thank them. I also want to thank the interpreters, the Spanish interpreters, because I know I speak very fast and sometimes I use a lot of medical language and it's not easy. So thank our Spanish interpreters for doing a great job with that. And I also want to thank all of you listeners who are out there working really hard on our populations that are our target populations. They're having a hard time sometimes. So thank you very much for all the work that you're doing.
I'm just going to interject really quick. There are 2 people with their hands raised. I can go ahead and unmute you and you can just go ahead and ask your question. So I'm just gonna unmute, I think it's Gypsy first. Go ahead, you can ask your question.
No, I'm looking for the emoji, I'm so sorry, but thank you, great presentation. I'm very respectful the information because it's amazing. Thank you so much for the clarification for the antiviral function. Thank you.
Great, thank you so much.
You're welcome. Yeah.
All right, Nereida, go ahead.
She's still muted, Martha.
Nereida, you can go ahead and unmute if you would like to ask your question. Well, in the meantime, there are no other questions that have come in.
They're a quiet bunch today. We usually get a bunch of questions.
I'm just gonna keep this up for just another minute or so to give you guys a chance. Thank you. And I guess while we wait, I'm just gonna tell you guys again, I will be sending a follow-up email later today with the links to everything, the slides, the recordings, the evaluations. A big thank you to our presenters, Amy Liebman and Dr. Laszlo Medeiros, and to our wonderful interpreters, Susana and Gabriela, who were joining us today. And I'd also like to thank Roxana for helping me out with the Spanish presentation. So thank you all, and I'm just going to go ahead and wait another minute or two in case one of you has a question. Thank you. Thank you, Sylvia.
If there are any clinicians out there who have used metformin, I would like to hear from you because I do not use that yet. This metformin study is very interesting. So if you have used it, I would love to see how you're getting along with it.
All right, I'm going to go ahead and let everyone go since I don't think anyone has any questions. And like Dr. Laz said, if there are any clinicians out there that have actually used metformin for their COVID patients, do follow up with me, and I will let Dr. Medeiros know and you guys can connect. Again, thank you, everyone. We hope to see you guys in our next presentation. Have a great rest of your week.
Thank you, Martha.
Thank you, Martha.
Thank you.